Good evening, everyone. Good evening. There we go. Good evening. Thank you. Welcome to the Baltimore Museum of Art. I'm Usman Naeem, the Dorothy Wagner Wallace Director here. It is truly a privilege to be here with you tonight. I guarantee you that what you will be listening to tonight will make you think twice about the ways in which art can activate so many parts of our minds and so many parts of this city. There is a moment that I think we all wait for when we are looking for certain kinds of artists. And the artist that we're honoring tonight, LaToya Ruby Frazier, has risen to that moment. This extraordinary, powerful, and moving installation created by acclaimed artist and activist LaToya Ruby Frazier is about collaborative storytelling. Storytelling that captures the voices and the stories of remarkable people from whom we are about to hear. In many ways, this is a homecoming for the artwork, which was always intended for the Baltimore Museum of Art. More Than Conquerors, a monument for community health workers of Baltimore, Maryland, 2021 to 2022, has been shown in Pittsburgh, where it won the Carnegie Prize. It's then been shown in New York City at the Gladstone Gallery. And then a portion of the artwork was featured in LaToya Ruby Frazier's retrospective at the Museum of Modern Art this summer. Now the entire artwork is here in Baltimore, where it belongs, and a permanent part of our collection, thanks to a generous gift from the Glenstone Museum co-founder, Emily Rales. And we had a celebration a few weeks ago with many of the community health workers, and what I said that evening is, like it or not, whether you have ever set foot in this museum, you are now part of our permanent collection, and you will be on our walls for generations to come. So I think they like it. More Than Conquerors is not only an artistic achievement, but a profound social statement that bridges art and activism to highlight the necessity of community-centered healthcare. It's a compelling reminder of the environmental challenges encountered in the communities you serve, we all know, and a tribute to the resilience of Charm City and Baltimoreans. I'd like to take a moment to name the healthcare professionals and advocates immortalized by LaToya Ruby Frazier in the artwork. Please rise. Last time we had each community health worker do a little dance. If you want to do a little dance and you're standing up, you can. But please rise as I call your name. Deal? Okay, Tracy Barnes Malone. LaCarrie B. Dawson. Dr. Lisa A. Cooper. Karen Dunstan. Kenya Ferguson. Griselda Fun. Erica Hamlet. Reverend Deborah Hickman. Dr. Anika L. Hines. Dr. Chidinma Ibe. Kendra N. Lindsay. Donnie Missouri. Vida Moore. Helen Owanda. Gregory Rogers. Scott Tiffany. My goodness, we did that before. Tiffany Scott, my apologies. Sorry. Wilfredo Torriente. Latish Walker. And the late Evelyn Nicholson. Just a moment to recognize that Evelyn is no longer with us. I wanted to say that these incredible human beings are heroes. They are the conquerors. They provide both care and hope. They go door to door. We are proud to salute you here at the Baltimore Museum of Art. Thank you. Because of LaToya's incredible body of work tackling industrialization, Rust Belt revitalization, environmental justice, access to clean water, access to health care, and basic human rights, the BMA will honor her with one of 2 inaugural Artists Who Inspire Change awards at the BMA Ball and After Party on Saturday, November 23rd. Congratulations, LaToya. A few of the incredible team that worked on this project are here with us tonight, and I would be remiss if I didn't thank them. Jessica Bell Brown, our former BMA Curator of Contemporary Art. Jessica has left us. She has flown the nest, as they say. I'm very proud for all that Jessica is doing as the Executive Director of the Institute of Contemporary Art at Virginia Commonwealth University. I'd also like to thank Antoinette Roberts, Annie, BMA Assistant Curator of Contemporary Art. Thank you. And finally, I'm very grateful for the exhibition's generous sponsors, and I would like to say partnership, and truly shoulder-to-shoulder partnership with Johns Hopkins University and Medicine. Dean DeWeese is here tonight. Dean, thank you for showing your support for this incredible work. I'd like to also thank Care First, Blue Cross Blue Shield for their sponsorship, and finally, Dr. John Meyerhoff and Linnell Strochi Meyerhoff. We also have another event in November that will be taking a deeper dive into issues around health equity. For those of you who may be wondering why this museum, an art museum, is going into this area of discourse, it's because of LaToya's groundbreaking leadership. Art should be talking about these issues. LaToya, thank you. Thank you. So thank you all for joining us tonight. It's truly an honor to be welcoming you to this conversation. I'm now going to hand it over to Jessica Bell Brown. Thank you.
Thank you, Asma. We've waited for this night for so long, and it's here, and I'm just thrilled, and the Kleenex is way too far away from me right now. I'm going to handle some business right now because we're a little behind. However, I'd be remiss not to say that, LaToya, thank you so much. The gift of the monument is that it reverses this paradigm that's quite archaic in museums, right? That curators acquire a work and artists, have that milestone of a museum acquiring that work. But I think what we see in the monument is that Frazier has unlocked for us this hierarchy and has shown us as an institution that we are the privileged ones to shepherd the stories and testimonies of folks like the CHWs. So I have to thank you for that paradigm shift through the platform of your work, LaToya. I also have the privilege to share a bit more context around the occasion for tonight. I have to say, when we acquired this work last year, it was Dr. Lisa Cooper who had a vision for this program tonight. And I cannot believe that we're here now, many, many months later. It's extraordinary to think about how two incredible women powerhouses in their fields have a shared vision for elevating the work and the legacies of the CHWs. So Dr. Cooper is the Johns Hopkins Bloomberg Distinguished Professor of Equity in Health and Healthcare, and a general internal medicine physician and health services researcher, and also the founding director of the Johns Hopkins Center for Health Equity. And as fellow MacArthur geniuses, Dr. Cooper and LaToya Ruby Frazier's friendship and exchange over many years evented their collaboration, which would bring Frazier into dialogue with Dr. Cooper's ongoing research and into contact with her longtime colleagues in the public health world, Dr. Chidinma Ibe, Dr. Anika Hines, Reverend Deborah Hickman of Sisters Together and Reaching, and the Maryland Community Health Worker Association chairwoman and president, Tiffany Scott. So many of you here tonight might be familiar with Dr. Cooper's groundbreaking book, Why Are Health Disparities Everyone's Problem, published by Johns Hopkins University Press. And I'd be remiss not to also mention that Dr. Cooper is also a member of President Biden's PCAS, Science and Technology Advisory Board. So these incredible powerhouse researchers, clinicians, and advocates all knew that this monument would create a platform for the very important discussions that you'll hear tonight. And we owe them and the community health workers our utmost attention. Tonight, we see one culmination of their visions to shed important light on the heroism, selflessness, generosity, and resilience of the CHWs who fight every day on the front lines for a healthier, equitable, and self-determined community right here in this city. So before we welcome Dr. Cooper to the stage, you're about to see in a brief video the story behind the Center for Health Equity's research and partnerships with community health workers in Baltimore that undergird and give further context to the glorious and powerful work of art that you see in our galleries. So thank you.
My name is Lisa Cooper. I'm founder and director of the Johns Hopkins Center for Health Equity and the Bloomberg Distinguished Professor of Equity in Health and Healthcare at Johns Hopkins. I grew up in a small country called Liberia on the west coast of Africa, and it's a low-income country. Fortunately for me, my parents were professionals and I had a lot of opportunities, but I saw children around me who didn't have those same opportunities, and I always felt that it was unfair and that everyone deserved to be healthy. And based on that, it's not surprising that I ended up in a career focused on health equity and health disparities. When I started my training in internal medicine, I noticed that people had problems that were not just medical problems. They had other problems, whether it was due to crime going on in their neighborhoods or difficulty getting jobs, being able to afford the food they needed or the medications they were supposed to take, problems that many of us may not have ever encountered ourselves. And when I started doing research on health disparities, people were actually not really testing solutions at that point in time. When it came time to start looking at solutions, I borrowed from public health this whole idea of community health workers and sort of brought that into the medical world. The lived experiences of community health workers is so pivotal they actually know what the solutions are most of the time. And so for research on community health workers, it certainly makes sense to have them share their own story. And that's why we did the photo voice study, is because we really wanted people to see through the eyes of community health workers what it's like to live in their neighborhoods and to navigate those challenges. We had this wonderful opportunity to collaborate with an artist and to make this available outside of healthcare.
What could happen between a collaboration with a doctor and an artist? Several years later, here we have this beautiful workers' monument, which really came into existence through my relationship and friendship with Dr. Lisa Cooper.
And we were talking about how she uses her art to elevate the voices of people who have been marginalized, and how I use my science and my research to do similar things. It's a story of how each individual came to want to bring about change in their community for the better.
My name is Chidinma Ibe, and I'm an assistant professor at Johns Hopkins University. I always wanted to do work that brought people into the research process itself as collaborators and not just subjects, particularly racially and ethnically marginalized communities. As a first-generation American, my parents are from Nigeria, and as I was growing up, I noticed that immigrants tend to come together and work in communities to support each other. And so I was always really intrigued by this idea of community. I first got introduced to community health workers right after I graduated from college, and I just fell in love with the whole model. And I remember thinking, this is exactly what I want to devote my career to doing. And a lot of the research that I focus on is the role that community health workers play in helping people become healthy and maintain their health over the course of their lives. I've had the privilege of working with community health workers for over 20 years now. Over that time, I've also learned the importance of focusing on CHWs themselves, because they are not just a means to an end, the end being you reduce disparities, you improve health, all of those kinds of things. They're also worthy of being respected, of being uplifted. They're worthy actually of also even being the focus of research themselves. What working with Dr. Cooper has done is it's affirmed that the way that I want to do things can be done in a manner that is scientifically rigorous and impactful for the communities that are the primary focus of my research.
I never would have thought all those years ago that we would get to a point where we would be able to have a video and an exhibit about community health workers and a whole program of research that uplifts them and centers them. It's like a dream come true.
It really is for me too. So yeah, I'm paying you forward.
Yeah, I'm trying to do that too.
I know, I'm proud of you.
Oh, thank you.
Thank you. Good evening, everyone. It's my honor to welcome all of you to this discussion and celebration of Baltimore's extraordinary community health workers. We were thrilled to collaborate with LaToya Ruby Frazier on the powerful Than Conquerors monument, and we're pleased to offer this opportunity to share more about the participants' contributions and hopes for their field. Thank you for taking time out of your busy lives to share this evening with us. Centering the margins speaks to amplifying the voices of this core of frequently overlooked professionals. While often serving on the outside of more traditional forms of healthcare, community health workers' contributions and expertise and their ability to assist patients in their own communities are crucial to our efforts to achieve health equity for all. So, who are community health workers? Also known as CHWs, they are frontline public health experts who establish trust in their service areas and have an unusually close relationship and understanding of that community. This foundation enables them to serve as crucial links between health and social services, especially for those who have less access. From a model established in the 1950s, this workforce has grown to 58,000 members in the United States alone. CHWs are proven to benefit health systems and patients. A 2003 University of Maryland study utilizing CHWs reduced emergency room visits by nearly half and hospital admissions by 1/3 among the 117 patient participants over a 2-year period, while also demonstrating that the work of CHWs can lead to hundreds of thousands in annual savings to Maryland Medicaid. Our own 2011 study found that patients who were coached by community health workers asked more questions in their medical visits and had better blood pressure control levels over a 1-year period. In Pennsylvania, a 2018 study found that patients with multiple chronic conditions in high poverty areas who had Medicaid or no insurance were 80% more likely to report that they had the highest quality of care if they received assistance from a CHW. I'm happy to report that Maryland and Baltimore are at the national forefront of CHW employment and are leading the charge to support these incredible individuals. However, we cannot end here. We need standardized practices for CHW certification and deployment to establish appropriate benefits and recognition for them compared to other health professionals. And we need to advocate for consistency in funding sources, structures, and reimbursements within and across states to increase CHW job security and maintain the CHW workforce. I hope that the photos and narratives of CHWs so artfully presented by Ms. Frazier and the photos taken by CHWs themselves as part of a Center for Health Equity Research project will deepen your appreciation of this vital workforce. If you or someone you care for struggles with medical conditions, I hope you'll consider asking your doctors about working with a CHW for support. I hope you'll think about asking your public health department if they have CHWs where you live. I also hope that those of you in leadership roles in healthcare systems or in the policy arena will examine current CHW workforce policies and laws to better support in the form of wages, benefits, working conditions, job security, and professional opportunities. I hope our panel discussion inspires you to uplift these dedicated workers as you come to understand how their experiences position them as health equity leaders. I'll close by thanking our key collaborators, Mrs. Tiffany Scott, Reverend Deborah Hickman, Dr. Anika Hines, and the CHWs who participated in the Photo Voice study and the monument, including our planning committee members, our Johns Hopkins Center for Health Equity staff, faculty and trainees, our families, friends, and community partners who provide unwavering support. And a quick shout out to my mom, who's 95 in the audience. I also like to thank several individuals for making this event possible. Anna Marlis Burgard of the Johns Hopkins Wavelength Research Engagement Program, Asma Naeem, Jessica Bell Brown, Tracy Beal, Antoinette Roberts, Anya Jaka, and all of the staff at the Baltimore Museum of Art. And finally, thank you to Johns Hopkins and Care First Blue Cross Blue Shield for their sponsorship of Than Conquerors, and to Bloomberg Philanthropies for their enduring support of our center's work. And now, I'd like to introduce you to Dr. Chidinma Ibe, a social and behavioral scientist, assistant professor of medicine at Johns Hopkins, and associate director of patient and community engagement at the Johns Hopkins Center for Health Equity. I've known Chidinma for more than 16 years, since she was a doctoral student and my mentee. She's become a valued colleague and friend, and I'm so grateful to her for her leadership in our CHW research projects. Dr. Ibe will moderate our panel discussion with 3 fabulous CHWs. Thank you.
Good evening. It is so wonderful to see you all, to welcome you here. Dr. Cooper, thank you so much for your lovely remarks, and on a personal note, thank you for being such a wonderful mentor and friend to me and to many other people in this room. As Dr. Cooper said, and as you probably gathered from the video, my name is Chidinma Ibe, and I'm really grateful to be here with you all today. We're just so excited to have the opportunity to highlight the role that community health workers play in advancing health equity here and beyond. I have to confess that of all of the parts of this evening's event, this is the one that I've been the most excited for. Because we have such a wonderful opportunity to hear from 3 outstanding community health workers. And so at this time, I want to invite Ms. Madelin Martinez, Mr. Will Torriente, and Ms. Latish Walker. Madelin is currently the Assistant Director of Advocacy at Catholic Charities of Baltimore. She has over 8 years of experience in health and human services, focusing on community building, policy advocacy, and immigration. Mr. Will Torriente is the Program Manager at Ascension St. Agnes Hospital Responder Program and Mobile Health Clinic in Baltimore City. He holds advanced degrees in public health and human services, and through his extensive experience in community engagement and advocacy, is dedicated to serving underserved populations. Last but certainly not least, our sparkly friend Latish, a community health worker at Johns Hopkins Medicine. Latish has over 27 years of healthcare experience and has spearheaded many initiatives, including walking tours of East Baltimore for incoming Hopkins resident physicians and Turnaround Tuesday's food and care package delivery program during the COVID-19 pandemic. One thing I want to highlight is that we know that each community health worker, even sitting in this room right now, has their own unique story that is compelling and worthy of attention and praise. And really through this panel discussion, what I'm hoping and what we're all hoping is that you will consider their individual stories and the collective power that community health workers bring to their work, and that you will get a sense of why community health workers deserve to be regarded as health equity leaders. So with that, I'd like to ask you all to answer a question. What is it about your role as a community health worker that helps you connect with patients in a way that's different from traditional forms of medicine or medical care?
Thank you, Dr. Ibe, for the question. First and foremost, I'm honored and humbled to be here tonight, and just want to uplift this work. I would say for a community health worker, it's the lived experience. Understanding underserved and marginalized communities, living in those communities, and providing services for those communities. A lot of the resources that I refer to, I've actually used myself, right? So I have a direct relationship with those persons, and I can streamline and fast-track referrals through those agencies. The CHW is basically like a GPS along the health journey. They help the patient navigate through different challenges and barriers. We're often the translator, we're often the bridge between the patient and the provider. Just to give you like a scenario, you have Mrs. Jones. Mrs. Jones goes to see the doctor's talking about A1C, diabetes, glucometer. Ms. Jones is just here because she's talking about her sugar's high. So we have to translate that and make sure that Ms. Jones understands that. The doctor sees that Ms. Jones is not making her appointments. She's not really coming to the appointment. So, but the doctor doesn't know that Ms. Jones has transportation insecurity, or there's no one to actually watch the children. The doctor says that Ms. Jones is not taking her medicine. He doesn't know that Ms. Jones doesn't have the copay, right? Or Ms. Jones doesn't have electricity to properly store the medicine. So as the CHW, our job is to peel the onion and find out what the exact nature of the problem is and assist that patient along their journey. And I'm just proud to serve with my colleagues.
Thank you, Will. That was great. And I would like to piggyback off of that. When I think of a community health worker, and I think of the community, and I think of the patients, and I think why we're able to connect with the patients the way that we do, I think about the fact that I was homeless, right? So I understand what it's like when you can't make it to a doctor's appointment because life is so overwhelming, right? I have 2 sons, and when we were homeless, they were above the age of 12. And I don't know if you know this, but in Baltimore City, if you have a son, not a daughter, but a son that is 12 years or older, they can't go into a family shelter with you. So now you're talking about separating families, right? I also understand what it means to have systemic oppression work against you. When you've done everything that you felt like you should do on your end. I graduated from high school, I went to college, I had my vocational training, I was a medical assistant, and I still had doors closed in my face. And there were times where I could not afford my son's private tuition, where he would miss like a week out of school at a time. And so I also know what it feels like to feel defeated or feel like a failure as a parent, right? I also understand that when I'm in a doctor's office, sometimes I personally have requested my medical records. I personally have seen some of the things that were said about me in this documentation, and I think to myself, that's not what I said. Where did they get that from, right? So I understand also what it means to be discriminated against or mislabeled or considered non-compliant, right? When it comes to healthcare, because they're not looking at the individual. They're looking at the numbers, the data, right? And so when my patients have an issue with anything, today, for example, I was about to hop in the shower to come here and I had a phone call. And my patient said, my medication did not show up. I got a notification saying that it was an insurance issue. When I called the pharmacy, they said, well, it's not really an insurance issue, it's just out of stock. Why would they not have said that to her, correct? So now she's like, I left a message, but it's gonna take forever before someone receives this message, but I need my pain medication now, right? Don't even worry about it. What medication do you need that's not available? What other pharmacies do you go to? I'm going to directly message your provider. I'm going to make it a high priority so that you can get, now, 2 things are going to happen. Either you're going to get a call from me or you're going to get a notification from the pharmacy to let you know that the prescription has been put in. The patient said, thank you so much. You're the reason why I'm still here today. I thank God that I have you in my life. I have never had anyone work as hard for me as you do, Latish. And I said, it's not me at all. This is what I do. Do you mind if I share this story tonight? And she said, please do, because everyone needs to know how amazing you are. Now, she said amazing I am, right? But the reality is you can take my name away and put any community health worker's name there. How amazing we are.
You always make me laugh, and I appreciate you for that. In addition to that, as a community health worker, my experience, what allows me to connect with my patients that is different than what people get in a regular healthcare setting, is the fact that I know what it's like to be looking from the outside in. I grew up as an immigrant, and I was thrown into a system that I really didn't understand, into a language that I really couldn't understand as fast as I needed to. So understanding the system, understanding how to fill out insurance forms, we don't have third-party payers where I come from. It was, you either have the money or you don't, you get the care or you don't. So that perspective allowed me to connect with the patients that I work with. Most of them were immigrants from all over the world. Sometimes it was like a little United Nations at the clinic where I used to be. In addition to that, living in poverty was another way that I was able to connect with people. When we were making decisions about the treatment, I knew what it was like to choose between buying your groceries or buying your prescription. And it's not an easy decision. And I know doctors want the best for their clients because I've seen it for their patients day in and day out. But sometimes we have to make hard decisions because the insurance doesn't cover it and the person perhaps does not have enough money to cover the copay. So I knew what it was like to do that. It was more than just providing medical care. It was about ensuring that the person will follow through with the medication and the treatment that was needed. And now let me add another layer to that relationship that I was able to build with the people I served, the language. As I had the opportunity to train and interpret for people at clinical settings, and I saw day in and day out the fear, the anxiety, sometimes the first time that someone had access to care in this country that they had never seen before, but at the same time, the fear that after that moment, they perhaps couldn't come back and follow up with whatever the prognosis or diagnosis was made. So as a community health worker, what makes us different from the work that is done at a regular community setting is that we bring us as a whole. It's not just the individual that is there with knowledge about the system, but also the experiences that we learn throughout our lives that bring that compassion and care and that empower others to continue through with their medical care.
Before I move on to the next question, I just wanted to point out a couple of things that really stood out to me. One, the impact of your lived experiences on the way that you approach the work that you do. But I also just wanted to thank you for your vulnerability in sharing how your life experiences dovetail with the way that you approach the communities that you work with and the empathy that you exhibit when you do what you do. So I felt like that should be uplifted before we move on to the next question. I love that in responding to the question I posed, you all talked about your personal experiences, but what I want to ask is for you to think about the most memorable client or patient or family that you've worked with. What was that like? What were some of the challenges that you encountered? What were some of the successes? Do you mind just kind of walking us through that? I know we don't have, like all the time in the world, but briefly, which will be hard. Not because of you, it's because of the depth of your experiences. I'm sorry.
It's really because of me, but that's all right. We're going to let that slide. I'm just joking. So I'll start with this question. The lights are kind of dim. I was hoping that I could see like someone in particular in the audience that I'm going to embarrass. Thank you for putting up the house lights because I'm about to embarrass this person. Okay, in a great way. So I was in my office a few years ago doing my work, and I get this phone call, Latish. Actually, it was Tish. I have a doctor's appointment. I'm here at Johns Hopkins, right? But I'm over on the Zayed side, which is, if you don't know, that's the Orleans side of Johns Hopkins. But my appointment is in the women's clinic over in Nelson. And those of you that don't know, that's on the Wolf Street side of Johns Hopkins, right? Now, I've lived in Baltimore pretty much my whole life. And I did not know until I started working at Johns Hopkins that it has its very own zip code for as long as I've known, I mean, 21213, but that was a lie my whole life, right? So then I realized, wow, it's such a big institution that it literally has its own zip code, right? So now here we are. How are you going to navigate across a zip code? Let's talk about it. Can you please go to the clinic and register for me? Let them know that I'm here. Can you show up as my community health worker? Absolutely, no problem. I go over to the clinic, I go to the kiosk, I register not as myself or someone else because that's an option. I do all of those great things. When the patient's name is called, I go up to registration to the front desk and I explain the situation. The patient is here, but they have to get over here from the Orleans side. Well, we can't check the patient in until the patient is actually here. Whoa, wait a minute. But the patient is in the building, right? And so we have this thing called a 15-minute grace period. It takes about 20 minutes to walk the hospital. So now you're talking about this patient their appointment is going to be canceled because they're missing their grace period by 5 minutes because they are here, but they have to navigate this zip code, right? No problem. I let the patient show up, and I say, listen, they're not trying to see you because you got here after your 15-minute grace period. Don't worry about it. Can I see the office manager, please? This is as a CHW when you begin to advocate, and this is when the challenges come in, right? Let me see your office manager. No, we're not going anywhere until I see your office manager, right? Office manager pulls myself and the patient into a room. Immediately, before we could say anything, patient was late, patient has to reschedule, never even got to open our mouth, right? I let them say all of that. And I say, through no fault of the patient, is the patient late? It is not the patient's fault that when they received their appointment reminder, it said, please come to 1800 Orleans Street. And they did a dry run. They checked the bus schedule because they had to catch the bus to get here. They have a cane, so they have difficulty ambulating. And then you've sent them on the other side of a zip code. And then you expect them to be here on time. And then you're going to tell them that they can't be seen? When you know this is a place where once your appointment is canceled, it's going to be months before they are seen again. What are they going to do about their condition between now and then? This is unacceptable. And because the patient did everything that they had to do to get here, I need you to rectify this. 1 second, let me see what we can do. 5, 6 minutes passed. It wasn't even 10. Office manager comes back. Now, the appointment was at 11. We have a 12:30. The patient needs to be here. Don't even worry about it. The patient will be here at 12:30. We're about to go eat some breakfast, and we'll be back. What the patient said to me after we walked away, they said, thank you so much, because one, they never want to go to Bayview ever again because they were traumatized with navigating Bayview. Now, here they are, having to deal with that same trauma, trying to navigate the downtown campus. And what they said to me was, had you not been there, I would have walked away and I would have not been seen and I would have felt defeated. But because you were there, I know what questions to ask. And I know now how to advocate for myself. That person is here tonight, and that's my mother. Can you stand up? So I say that to say, she now advocates for others, right? This is what we do as community health workers. She doesn't really need me anymore, and I'm okay with that. She still calls on me. But when she calls on me, most often it's, oh my goodness, I just helped somebody with this. I gave somebody a resource. I did. So we are all community health workers. And that's my story. Thank you, Mommy, for letting me embarrass you.
It's hard to follow that. One of the most memorable cases that I remember is I was sitting in a waiting room waiting for the pap smear results for a client, and I had to give the news that the pap smear results were abnormal. I remember as we were waiting, having to calm her down. Her biggest fear was being a burden to her family, concerned that she had to go back to work and it was taking longer than she thought it would be. So she was afraid that she wouldn't have a job after the appointment was done. And it was just the fear that the fact that we were there together and we were waiting for those results. But in a way, whatever was in that envelope could really change the rest of her life. And as the doctor came out, I had the difficult task of interpreting what the results were. And unfortunately, the results were abnormal. So then another set of questions came up. How am I going to pay for this? Where do I go next? I have 3 kids. Would I see them graduate? And in my job at that point, I thought, oh my gosh, I am not trained to provide this emotional support. But then I remember what I would like for someone to do for me at that moment. And trying to put together the answers, I couldn't really, it was a challenge for me because I couldn't relate. I've been able to relate at so many levels with the people I serve through language, through share experiences. But at that moment, we had a different experience that I wanted to be respectful and also wanted to help. So I remember we prayed. Through prayer, we found connection, we found relief, and probably people would stop by and think, why are they praying? I have my badge and everything. Like, why is she praying? Is that part of her job? But that's all I knew to do. I wanted to bring comfort. I didn't know how we were going to pay for it. I didn't know any of that, but I knew that prayer brings peace, prayer brings clarity, and in the mercy of God to bring to that moment, and we'll figure it out. We'll figure it out together. Thank goodness we were able to get the care that she needed through partnerships that we had. Her job, we worked with her boss to make sure that she could make the appointments, provided transportation. And thank goodness, also her follow-up appointments were not as bad as we thought they would be. So, but can you imagine if at that moment I wouldn't have been able to connect with her, to figure out a way to connect with her? It would have been a different story. We would have had a panic moment to share or something else, but we had prayer. So the jobs that we do require us, we were just talking about that earlier. Everything we learn in life, when you're a community health worker or at any point, we bring that to the table when we're supporting others going through different challenges. And sometimes we see ourselves in those challenges. Other times, we just need to figure out what will connect us at that moment.
Prayer. Prayer, amen. For me, I would say my proudest moment as a CHW was a young lady that I worked with in the emergency room. Looked in the chart before I went to see her. She was labeled as aggressive, mean, nasty. The nurses didn't want to see her. They wouldn't take labs. And so in my mind, I'm prepping myself to go see this patient. And when I go in this room, this lady's like 4'5" and like 90 pounds. And so she's already stigmatized in the system, right? And I go in to meet with her. She was assaulted with a milk crate. So she's beaten her head with a milk crate by her partner. So she was suffering from intimate partner violence. She had chronic substance use disorder. She had behavioral health on board. A lot of things going on, a lot of moving pieces. And she wanted to leave against medical advice. And she didn't want to do an assessment, she didn't want to talk, and like you said, I prayed with her and was able to de-escalate the situation. And she wasn't really sure what she wanted to do, but I asked her, I said, if you give me 1% of your trust, I'll work to earn the other 99. And she trusted me. So I sent her to Gardenzia in Crownsville because I didn't want to send her in the city. I didn't want to have a way of getting back into the area. So my mind frame was send her out of Baltimore. She stayed in Gardenzia for about 2 days, called me about 30 times, and she left. And she didn't sign a release of information, but she gave me her mother's number, so I connected with her mother. So her mother saw that I was really sincere about helping her daughter, so we had a relationship. And I worked with the mother, I worked with the daughter, and eventually got her back into treatment. Today, she's no longer homeless. She works for the state of Maryland. She has her own car, she has her own apartment. We check in, we talk once a month, and I'm just blessed to be of service, right? So my goal is to always leave somebody better than I found them. And the level of service I want to provide is the level that I would want you to provide for my family member. That's it, that's all.
I really loved everything that the three of you just said, and there are certain things that stood out to me. One, just this idea of seeing beneath the surface. I was taking notes when I was listening to you all because I personally feel that I don't want to miss anything that you all are saying. Just this idea that you're able to see beneath what others are looking at. So whereas some may see someone who is non-compliant, you see their humanity, you see what is really going on. And Latish, you really buried the lead when, you said that that person was your mom. I was so curious. That was great storytelling. But I just appreciate the ways that you have highlighted really what it looks like to walk in your shoes and to support the people that you work with. And so I'm sorry to say that I have one last question, and I wish we could keep talking, but what I would love to know from you all is, what do you want people who are less familiar with what you do as community health workers to come away with from this exhibit, from this event, whether they're policymakers or people who work in public health agencies or insurers?
What I would like people to take away from tonight is that the jobs community health workers do are worth protecting. And this is based and this is based on the way the things are right now. The state is heading into a $2.6 billion deficit as we are getting ready to initiate the 2025 legislative session, which means everything is on the table. And I would love for policymakers, for advocates, to make sure that as they're making the difficult, if they're going through the challenge of balancing the budget, that they remember that these are not just numbers on a page, that these are lives that will be impacted. For some, all of us will be impacted. Transportation projects, school systems, all of it is on the table. But at the same time, we need to make sure that those who are the most underserved, people with disabilities, seniors, people who were incarcerated and are trying to get back on their feet, immigrants, single moms, single dads, all of them are protected. We cannot balance the budget on the backs of the most vulnerable. we need to make sure that we continue to fund these programs because they're essential and they would help navigate the systems, the difficulties as people are adjusting to the new way of life. So I want to make sure that we remember that as we go out, as you go home, stay tuned with what's happening in Annapolis between January and April. Look for your programs, protect what's already out there, and let's make sure that we find a fair way to balance the budget.
Hard to follow. Couple of things, couple of takeaways I would like you to ponder on. First and foremost, the community health worker is an invaluable piece of the complex care coordination puzzle. You cannot put a dollar amount on that, right? You talk about quantitative data, but the qualitative data, the lives that are changed through the work that we do, you cannot measure. Number one. Number two, when designing interventions for the community should be at the table when those interventions are being designed. Those interventions should be culturally sensitive. The providers should be culturally competent, right? And they should have an understanding and leave the implicit bias at home. My third piece is funding, right? We are the most underpaid, that do the most work, that go into the communities, right? You're not, the provider's not going into Latrobe projects to do a home visit. We are, right? We're going to sit in those roach-infested houses, right? Dodging guns and violence, right? And my thing is funding these organizations, right? So I would encourage policymakers and funders to basically fund community-based organizations, fund hospitals, fund interventions. I would be remiss if I didn't mention Reverend Deborah Hickman. This woman has poured into me and taught me so much about community health, and I wouldn't be where I am without her. And I just want everybody who's had an interaction or any part of community health with STAR, just raise their hand in this room. STAR has been doing this work in the community for 30 years before we knew what social determinants of health were, right? And without agencies like that, where would we be? Thank you.
So Madelin is our policy expert, you know, since she does work in Annapolis. But I'm going to give this a shot. I'm going to look at policy from an insurance state point of view, and I'm also going to look at policy as in policies, procedures, regulations from an institutional point of view. Statewide, we need our own CPT code, right? We need to be able to, and I say that because if we have our own CPT code, then the institution can build the insurance company for us, and we don't have to necessarily worry about where our funding is going to come from, right? Because it's coming from that premium that the insurer is paying for this. Every single time you go and see your primary care provider, there's a referral put in the system that they have to send to the insurance company. So why not every single time you see a CHW, there isn't a referral put in to be added to the CHP code, right? That's one. Two, We have a social work department. We have a caseworker department. We need a community health department, right? And it's easy to do. I don't know how to do it, but I know it's easy. This is why I say it's easy, because you already have a blueprint. You already have departments, right? So you can already take that template to create a department and modify it for community. Why don't we have an executive director of community health department? Why don't we have a president of the community health department? Why don't we have a program manager for the community health department? Why don't we have a program coordinator for the community health department? Do you see what I'm saying? Do you see how that goes? And so then you don't have to worry about shutting down these programs. Why? Because nobody's about to shut down the whole department, right? We're not case managers. We're not social workers. We're community health workers. When that social worker or that case manager hands you that pamphlet for that resource and you don't know what to do, it's that community health worker that's walking you through the process, right? Why aren't we in the emergency departments 24/7? There are community health workers that would not mind working a night shift, because guess what? Social determinants of health don't stop. People are in it, and so when you come into the ED at 4 and 5 o'clock in the morning, and you're like, oh, well, social work don't come in till 6 o'clock, 7 o'clock. But it's too late now, because you're about to get discharged at 5. Do you see what I mean? So where does your help come from? There is no reason why we don't have our own, and there's no reason why you have not created it. So I'm challenging those folk that's in this room that have the power of the pen, right? And if you don't have the power of the pen, you have the ear of the person with the power of the pen. I'm challenging you to help us get our own CPT codes. Help us be able to make sure we save our community-based organizations, and help us develop our own departments.
That was outstanding, all three of you. I think we have time for a few questions. We have 5 minutes for questions. So if any of you would like to pose a question to our panelists, please raise your hand and someone with the mic will come. Okay, there's a question here.
Hello, my name is Hydra. Hearing all of this is truly amazing. You know, I didn't know all of this resources myself. My question to you guys, and as a whole, as of May, I believe, they passed some type of legislation or something that made it so anyone, regardless of your pay range, Medicaid, joblessness, or anything else, has to pay regardless for their medication. So what can we do to help those people that can't afford those medications?
All right, I was asked to go first, so I'm going to do the best that I can. So I'm a big believer in confronting something doesn't necessarily have to be a confrontation, right? I am a believer in when you see something that is not right, you gather like-minded folk and you come together and you come up with a proposal, you come up with a petition, and you go to those folks. You go to Care First, how you doing? Yeah, you go to these insurance companies, right? And you say, show them that our patients cannot afford this, right? Because here's the thing. There are also other formularies that you can use. Why is it that you've decided Tell me the reasons. I need to understand what made you decide that every single person, regardless of where they are, when we all know equity does not exist when it should, how are you making this equal? Equal does not work for anyone. How are you making this so that everyone has to pay? What's your rationale behind that? Because honestly, I only see money, but you're already making enough. So I need you to help me understand why you are because now what's gonna happen is, you're looking at making everybody pay. When they can't pay, they're going into the emergency department, right? So now what? So putting it in a way that they'll be able to understand money and statistics, speak their language, but come with a backing behind you. And that's when you use, hi, my wonderful allies. That's when you use your allies and their privilege to get you in places where you couldn't get on your own.
I would also like to add, as an individual, you know the people that are going through hardships who need to pay for these medications. Writing a memo, you can look up who your politics is local. Look up who your legislative representative is. Write something short, something sweet that would provide a picture of the story and its impact on the person that you're, whose stories you're showcasing. But it's important for them to know that their decisions to make everyone pay for medication are impacting their constituents. It has an enormous impact. And add that to what Tisha said, bring more people like you to get them to write a story. They don't even have to go to Annapolis. Just flood their mailbox with information, their emails, and call them to make sure that they know this is impacting their constituents.
I concur with what both of them said. For me, it would just be more of a data-driven effort, looking at the poverty level in the community, and that zip code, looking at the community health need assessment, and how can we show the need, and as you said, going to the representatives, creating petitions, and being creative, finding ways to get around that, like pharmacy RX, right? Different prescription vouchers, different resources to kind of circumvent those policies until we have a better way to do it.
I hope you don't mind, but I also want to offer a thought about your excellent question, and I really wanted to piggyback off of everything that our wonderful panelists just said. But this challenge that I'm issuing is actually more for those of us who are not community health workers, who consider ourselves allies, that it's incumbent on us who have access to the data, who have the ability to network with people who, as Latish put it, even if we're not in positions of power, we have the ear of those in positions of power, to first of all understand the nuts and bolts of these policies. And that's one of the things I admire so much about Madelin. She's excellent in many ways, but in this regard, I learn a lot from her. So understanding what these policies entail, understanding the importance of community health workers leading the development of solutions and identifying the resources to circumvent, as Will so eloquently put it, these circumstances that we're navigating when it comes to how these kinds of policies are enacted and what they really mean for people's lives, and to just figure out how to stop operating in silos and come together and really just bring together our collective expertise. Because I fear that when we're siloed, we don't have a coordinated effort, and these things pass and then they adversely affect the communities that are already struggling. So I think everything that they're saying is completely on point, but I also think that those of us who are on the outside looking in, who are not CHWs, we owe it to you all to support the work that you're doing, to amplify what you're doing, your expertise, and bring it to the center of all of these different efforts. There's one more question, and the lovely woman in the blue. Oh, just kidding. There's someone back. I am so sorry. We actually have two questions, so you already have the mic.
All right,
my
my
apologies.
question is, why is not why the community not aware of what a first responder is in the hospital field? Basically, a hospital responder in the hospital, and why are they so underpaid?
I would say poor marketing. You have persons that exist within my own hospital that don't know what a hospital responder does. And I'm talking about medical execs. And we've done provider education. They've seen the work that we do. But you just have to continue to do the work and let your work speak for yourself, right? And show up and show out. And the word will get around about the work that you're doing. It depends on like who the funders are. There's a lot of focus on who's funding these initiatives right now, and certain news agencies are casting them in a negative light. Continue to help the community, do the work, right? Your work will speak volumes above what everybody else is saying. And also talk to your hospital marketing department. Have them create some flyers, community events, tabling, stuff that's going on around the hospital. What we're doing now is trying to establish the footprint beyond the hospital into the community. And so we've been fortunate to have different persons that were working with us in the areas in Southwest Baltimore that are allowing us to table at their events and highlight and showcase our programs, back to school events, and piggybacking on other people's events as well.
I want to just add a little bit to that. I believe in departmental training also, right? Because word of mouth means a lot. And again, like what Will says, even though we've been doing this work for a while, there's still a lot of departments that don't know or understand exactly what we do and how we fit in, right? So I'm a big believer in having departmental training with the staff, with management, so that when they have their patients come in, they can say, oh, community health worker, let me, right? First responder, let me, right? Because then they automatically know. So word of mouth, along with marketing, but until you can get to the marketing, because then you got to go through legal, making sure that the marketing is correct, blah, blah, blah. Word of mouth works really well, but in order for us to do that, we have to be able to sit down with every department. And honestly, I feel like it should be mandatory training that every single department knows what a community health worker is and how we fit into their department and how integral we are in the department.
I truly wish we could keep going, but we cannot. So I just want to thank you all so much for your attention. Thank you so much for attending and listening to our wonderful panelists, but above all, thank you to our outstanding panelists. They are so amazing. And everything that they shared really illuminated what community health workers do and their importance, and just know that we hold you all in the highest esteem. So what we're now going to do is we're going to leave this room, and we're actually going to look at the exhibit as well as partake in a lovely reception with food. Can't wait. And live music. And what I really encourage you to do as you walk through the exhibit, take in all of the stories of the community health workers who are showcased through the monument that LaToya Ruby Frazier spearheaded. And with that, we're done. But I would like to ask those of you who are community health workers, staff from BMA, Hopkins, and other program contributors to please come on the stage for a picture. So again, thank you so much.